So I'm just really quickly going to introduce our panelists for today, and then I'm just going to hand the reins over. So Sarah Christopherson is the Policy Advocacy Director at the National Women's Health Network, and she is responsible for leading the National Women's Health Network's legislative and regulatory advocacy efforts. She also directs federal policy initiatives for raising women's voices. And Jenny Dodson-Mistry is the Senior Manager of Special Initiatives at the National Institute for Reproductive Health, where she supports organizations doing proactive work to advance reproductive health rights and justice in cities and counties. She manages both the LARC Access Project with myself as well as all of our local level work. So that being said, I think it'll be easier for me to just kind of send it over. So I will let Sarah take over, or Jenny take over. Are you on the line?
Great. Yeah, thank you. Can everyone hear me okay? Great. I actually am going to have to ask Lauren to advance the slides because I'm having some technical difficulties and can't be a presenter. So I have a few times that I'm going to ask folks to chat something in, but unless you chat it to the whole group, I won't be able to see it. So Lauren, I'm going to rely on you to be my eyes on that. So thank you, everyone. Sarah, Lauren, and I are really excited to be presenting to you all today on this resource and on our work together. Just very quickly about the National Institute for Reproductive Health. We build power at the state and local level to change public policy, galvanize public support, and normalize women's decisions about abortion and contraception. One of our primary strategies is to partner with state and local level advocates. I'm hearing I'm a little quiet. Hang on one second. Does this sound better at all? Lauren, do you want to unmute yourself and tell me if it does?
I can hear you great. I think some folks are still having a hard time hearing you. It might be if it's over the web. It might be easier if you dial in. Just a note to anyone who is listening both on the web to not have the web dialed in as well as the audio. Pick one or the other, but that might be it. Yeah, it seems like phone audio sounds really well, and the web audio might be faint. So that's just a note. If anyone's having difficulty hearing, maybe log off on the web audio or mute your mic on that and then call in.
Great. Okay. So one of our primary strategies is to partner with state and local level advocates, and since 2008, we've worked with more than 170 organizations in 43 states and 64 localities. Next slide, please. Great. So this resource is grounded in what NIRH has learned through our LARC Access project, which was launched in 2016. So the LARC Access project addresses policy and systems level barriers on the state level that often make LARC difficult to obtain, and we do this in partnership with state organizations, as mentioned. So we use a framework that centers patient autonomy and choice. We do focus on barriers to LARC, but the way that we think about that is we need to address these barriers to ensure that all people have access to the full range of contraceptive options so that they can select and use the method that is right for them. And we know that specific projects need to focus on LARC access to realize that vision. I know that all of our partners up there look very small, but I really wanted to include all of them to honor that this really is where most of our expertise in LARC comes from. At the end of this presentation, I'm going to talk about some of the support that NIRH can offer to anyone that's on the webinar and is interested, and that's definitely true, but we learn just as much as we offer our partners, and really a lot of what we're talking about today is learning from the lens and the framework that our partners have used, and then just the work that they've done and the things that we've worked through together. So this is not everybody. As I said, we've been doing this since 2016, and if you're interested, you can see the full history of the project on our website, but I really want to acknowledge all of what we've learned from our state level partners. Next slide, please. And I think I'll turn it back to Sarah.
Hi, folks. just a quick background on the National Women's Health Network. We were founded in DC in 1975 to use policy analysis as a tool for change. We are feminist health activists supported by a national membership. We do not accept financial support from pharmaceutical or the medical device industry, which can be critical when we're talking about drugs and devices like birth control. We have 3 core campaigns, but the most relevant for today's discussion is our work to ensure that people who can become pregnant have access to comprehensive, safe, and effective reproductive health technologies, services, and information without coercion or restrictions driven by ideology. The network has been working on reproductive coercion for 40 years. So if it's not too hard to see on this slide, you can see in that middle, we had I included our call to action that we circulated in 1979, asking for our members to speak up about forced sterilization and the need for policy safeguards against sterilization abuse. Next slide. And I'll turn it back to you, Jenny.
Sorry, I was on mute. So for today's objectives, so we are first going to provide some background on the history and present-day instances of reproductive coercion, then discuss the barriers to LARC access that need to be addressed by public policy, and then share strategies for analyzing and understanding LARC legislation and other policies, and for crafting effective person-centered policies. And I also say that because I wanted to just spend a second to talk about our intended audience for this resource. When we were thinking about putting this together, we were really thinking about state-level advocates who are pretty new to this topic. Either an elected official or a policymaker might have come to them and asked them to weigh in on a bill that they've written or to help them think of a bill to increase access to LARC, or maybe they've just heard about LARC policy a lot in the media or in the movement and wanted to think about something for their state, but didn't know, a lot about the subject matter and wanted some background and ideas for how to craft good policy. I say that because there's a lot of people that registered for this webinar who are brilliant and who we've learned from, and who I know at least the first half of this webinar probably better than I do, and who I really appreciate your guidance. So we hope that, understanding this resource, you'll be able to share it out with other folks, but I really want to acknowledge a lot of the expertise that, again, we've learned from national advocates as well. Since I'm not a presenter, I can't see who's actually called in, so I won't be intimidated by any of you all, but yeah, that is the intended audience. So thanks. And then next slide, and then I'll turn it back to Sarah. Now, Sarah, you might be on mute.
So we, as Jenny just mentioned, we have a very diverse group of folks on the call with lots of backgrounds. I want to start still with the history of reproductive coercion. I know folks are, in many cases, already familiar with at least the rough outlines, but I really want to center the discussion in that history or we lose the broader context. And here I actually really want to lift up Sister Song, our partners in this work for the last 4 years, and particularly Monica Simpson, who speaks with such strength and moral clarity here. For more than 2 decades, Sister Song has done amazing work getting advocates and providers to confront some really hard, uncomfortable questions about how race, class, gender identity, immigration status, and more shape how reproductive health care is provided in this country. If Monica were here, one of the first things she'd say is controlling Black women's fertility was the cornerstone of slavery. And I'll say that still reverberates through our public policy making today. It's just as an aside, if you overlay a map of states that haven't expanded Medicaid at all with a map of the slaveholding South, you've got a pretty good match. It's not a perfect match, but it's a pretty good match. So I want to center the discussion in history for a couple of reasons. Whether we're talking about slavery, whether we're talking about population control as a tool to erase indigenous peoples and cultures, whether we're talking about the forced sterilization of people with disabilities, low-income people, immigrants, we're talking about a group in power deciding who does and doesn't get the right of personhood to act with bodily autonomy. And that decision is always justified in the context of the necessary for the greater good. I think it's really easy to give lip service to the idea of coercion without actually changing how we think or what we do in practice. I saw this firsthand in 2016 after the election. Advocates were discussing how we should respond to attacks that we knew were coming on insurance coverage for contraception. And the response was, well, yeah, we don't want to be coercive, but really, we should only be talking about LARCs, and everyone should just go get a LARC. That mindset of we know best, and so we can make the decision for someone else because we're the experts, can sort of be appealing, but it has to be understood and evaluated within this broader social context. The other reason I want to talk about the history is that it's not ancient history. The last time that we know for certain that a state was sterilizing a vulnerable group without their consent was in this decade. So that inmates sterilized in California. That's not just within my lifetime, that's within the lifetime of my fourth grader. When we're talking later in this webinar about state-based public policy making around LARC access, it's really important to understand it in the context of past state proposals to force women to get LARCs as a shortcut to addressing some other public policy goal. And it's important to lift up just how racist and classist and ableist these proposals and their underlying assumptions are. So the one example in the bottom corner, immediately following FDA approval of the first implant in 1990, the editorial board of a major newspaper was promoting LARC as a way to, quote, reduce the underclass. Around the country, state legislators were proposing forcing mothers to get a medical device just to access basic shelter, food, clothing, heat, or to fix, I say in quotes, complex issues like substance abuse without fixing any of the root causes of these issues. Furthermore, in low-income communities all across the country, you can still find examples today of women who couldn't get Norplant removed. They had it inserted in one of these previous policy pushes, maybe at a school-based clinic that trained in insertions but not removals, maybe as part of a state program, but then they were stuck. So when providers are meeting with patients today, when legislators are designing contraceptive access bills, this isn't the distant past, it's recent personal context for millions of people. I want to give two very recent examples, one subtle, one less so, of how state policy decisions can perpetuate coercion. The first example is from the website of a state public health department, and I'm not going to name them because after we raised this, they changed their site, but the example is instructive. The site asked one key question: do you want to become pregnant in the next 12 months? And offered two choices you can click on, yes or no. Set aside for the moment that we know pregnancy intention is complex and that the framing around planning a pregnancy doesn't actually speak to everyone, doesn't account for a lot of cultural differences. We'll just take this question at face value. Do you want to become pregnant in the next 12 months? If you click on no, you see information about LARC methods and only LARC methods. You had to click on yes. Yes, I want to become pregnant in the next 12 months to see information about every other method, the pill, the patch, the ring, the shot, condoms, etc. Clearly, there's a right and wrong answer here, and clearly efficacy is the only thing that matters because it's the only way the information is displayed. The idea that someone who can become pregnant might value efficacy but might also have other potentially more urgent priorities is clearly secondary. One of the things I try to emphasize actually when I'm talking to providers is all of the other factors that their clients are considering. Is it important to have a method you can start and stop on your own? Is it important to have a monthly cycle? Do you need a method that can be kept private from a partner or a parent? If you have health insurance now, are you at risk of losing it? And that can go either way. You might want to secure a method now while you have insurance, or you might not want to get stuck with a method you won't be able to afford to get taken out if you don't like it. we can't presuppose those answers. So it's important for providers and for policymakers to not decide ahead of time what's going to be important for these very intimate decisions. The next example is less subtle and requires explanation, simply that for years a number of state programs wouldn't cover getting your LARC removed unless it was medically necessary, and certainly not if you simply wanted to exercise your right to become pregnant and to be a parent. All of this history and what we kept hearing from folks on the ground bubbling up led the National Women's Health Network to join with SisterSong in 2016 to develop the LARC Statement of Principles. Sets out a framework built on the values of reproductive justice for how to approach contraceptive access without coercion. The statement has been signed by over 100 organizations and several hundred individuals. I put up 2 key paragraphs here with the first and one of the closing paragraphs. You can read the full statement and see the full list of co-signers by following the link. And if you go to tinyurl.com/LARC principles, you'll see a Google document, because this is a living document shared between our 2 organizations, not owned by either of us, and we're adding new names all the time as we're trying to share this message about how to approach contraceptive access in a way that promotes personal autonomy and justice. With all of that, let me turn back to Jenny.
Thank you. Great. So now I'm going to provide some background on LARC policy today. Next slide, please. So, within that context, again, I want to reiterate that we do know that it is important to work on addressing barriers to LARC, that this is a line we need to walk between ensuring patient choice and ensuring access. So I wanted to provide a little bit of background on some of the barriers to LARC access that are perhaps not exclusive to LARC, but really raise up with LARC versus other methods of contraception. So the first is inadequate provider training in insertion and removal. So that could mean no training, that a provider has never done this before and isn't sure how to do it and doesn't have access to training. It could also just mean that they're not comfortable with it, that there isn't someone that they're practicing with who can help them train to competency, or for perhaps one of the other barriers on this list, they're not really providing a lot of LARC day to day and just, again, don't feel comfortable and up to competency. So LARCs are expensive, and that's one of the really key things. These devices can cost around $800. And while, thanks to the ACA, a lot of the cost sharing for patients that have insurance has been mitigated, that cost still exists, and it's something that providers and clinics and administrators have to deal with. One of the ways that shows up is that stocking several devices in your clinic, so that if someone comes in and wants an IUD or an implant, they could get it that day, can be really prohibitively expensive. That means laying out, several $1,000s to have a sufficient supply. And when you're operating on razor-thin margins, that just might not be possible. And then that really is coupled with inadequate insurance reimbursement. That can be reimbursement that's too low, it can be reimbursement that's too slow, it can be both. But again, a lot of clinics and other settings struggle with paying for LARC. As a result of that, or perhaps other things, there is often restrictive clinic or hospital policy around, whether you can offer a LARC. Perhaps there's a lot of hospitals that just are not offering immediate postpartum LARC, for instance, even if policy change has been made in their state, which means they should be able to do it without financial risk. So, insurance reimbursement could be inadequate. It could also be that you offered a few LARC immediately postpartum. There was an error with the claims were denied, and everybody got skittish, and they're like, we're not doing this. So that can become another barrier. And then there's really myths and fears about LARC and misconceptions amongst both patients and providers. And provider and patient education is really needed to help dispel those. I think I want to separate this out from patients who might be fearful or mistrustful of getting a LARC because of some of the history of coercion that Sarah talked about. I think that's really real, and that's what these policies, good policy would hope to allay and start to change the narrative around. But I'm thinking about things about, that LARCs aren't safe for you, or that they can cause infertility, or a lot of fear around insertion, which isn't necessarily unfounded, but which people might think is more dreadful than it really is. Physicians might think that you had to have had a child already to be eligible, or that they need to ensure that you don't have any STIs before they insert, and these are all things that are not actually true, and we can definitely do work to educate both populations about it and increase awareness of the option. Next slide, please. So we looked at LARC legislation in particular that has happened in the last few years, and just pulled out 3 trends. Again, I can't see the chat, but please feel free to chat in other trends that you think that we're missing, or bills that you care about, even if it's just one that you think we should know about that aren't in here. I don't know that I'll comment on it today, but I'd just be interested in what people think. What we have here is funding to purchase LARC in certain settings or for certain groups. So this is, again, responsive to that high cost of LARC for providers and wanting people to be able to stock it. This would be the state allocating funding to pay for LARC so that providers can stock them. Then we've also seen LARC pilot programs that are based on models from other states that have already run these pilots and had really impressive results. So this would be a comprehensive initiative that is focused on addressing a lot of the upstream barriers to LARC provision in addition to those cost barriers. So that would be looking at provider training and ensuring that billers and coders are up to speed, and that there's education on counseling, and it might sometimes also have a patient education piece. And then the last one that we wanted to talk about was changes to reimbursement. Up here I have for immediate postpartum LARC, and that's definitely the #1 trend, but I think it could just be changes to reimbursement to make LARC more financially feasible for providers in general. So what we really have seen is a lot of debundling of Medicaid reimbursement of immediately postpartum LARC, so that hospitals, in addition to their reimbursement for the labor and delivery, will also be reimbursed for at least the device, if not also the insertion. Next slide, please. Oh, and I'm going to turn it back to Sarah.
Analyzing proposals. We came up with a list of things that we think it's worth advocates to think through as they are looking at legislation or considering introducing legislation. First and foremost, what does the bill actually do? And does that match with how it's being promoted? One of my favorite examples from my past life was an amendment offered by House Republicans that was described as a way to stop federal employees from looking at porn on government computers. But buried in the last sentence, the amendment also eliminated all new funding for the bill. Porn was the Trojan horse for devastating funding cuts. Another question, who are the bill's major champions and why are they supporting it? If a contraceptive access bill is being driven by staunch opponents of abortion, it could still be a good bill, but it's important to explore what else is going on and why. Does the bill include new funding? Does it redirect existing funding? Are we robbing Peter to pay Paul? Are we setting up an initiative to fail because it doesn't have the resources to succeed? What, if anything, does the bill try to measure? And do the proposed metrics actually measure what's intended? And Jenny will say more about that later. What actions does the bill incentivize and for whom? It sounds silly, but does the bill give doctors a bonus for every LARC they insert? That's not going to incentivize patient-directed decision-making. So what behaviors are being incentivized? Is the bill being marketed to legislators and advocates as a solution for a separate problem, like poverty, like substance abuse? And there are a number of reasons why that can be problematic for advancing access to reproductive health care as a public policy goal in its own right. But I would caution that it can also be counterproductive in terms of cementing lasting policy change. It can set a project up to fail. Contraceptive access on its own isn't going to fix institutional racism, unemployment, economic stagnation, underinvestment in the community, physical or emotional trauma. all of the other factors that might be at the root cause of what policymakers are hoping to fix. The bill might not actually lead to Medicaid savings. And as I mentioned, pregnancy intention is complicated. It might not actually impact the pregnancy rate. If the bill succeeds in having gotten good, comprehensive, non-coercive contraceptive access, then it's a success. But if it's been set up to fail ahead of time by sort of couching it as a panacea, then that's going to lead to a lack of support for keeping the project in place. And I would say that doesn't mean don't recruit legislators and supporters using the arguments that they will find most persuasive. But I do think it means thinking carefully about the choices that are made, the long-term implications of those choices, and if they are in keeping with the sort of ultimate value of reproductive justice and personal autonomy. And lastly, what's the plan for implementing the bill? Does the bill empower an agency to fill in key details? And I think the Trump era has proven more than ever that agency powers and responsibilities really matter. And so knowing what's left up to those agencies and who's going to be staffing those agencies is really important. Now I'm turning it back to Jenny.
Okay, thank you. Yeah, so, that was a lot of questions, and we've got some more here. We particularly wanted to lift up some things to think about that should just raise a flag for you to look a little bit deeper, to think a little bit harder about the bill or the policy that you're being presented with or that you're putting together. And I want to preface this by saying that red flags that do end up being problematic, this might be inadvertent or it might be intentional. We've seen Sarah laid out evidence for intentional bad intentions, but sometimes people just aren't really thinking through the implications of a policy. And if you talk to your coalition and if you talk to the people that are designing the policy, you'll be able to resolve it without too much trouble. I was thinking about this morning and thinking about an example from several years ago where we were working with a state who had the health officials had understood that stalking was a problem and left that conversation and came to us and said, yeah, we heard stalking was a problem, so we're just going to ask in the budget for a lot of money, and we're just going to strike a deal with one of the pharmaceutical companies, and we're just going to buy a bunch of one type of hormonal IUD, and then we'll put that out to all of the providers, and it'll be fine. And we were like, they just hadn't really thought through that there's multiple types of IUDs, and there's also the implants, and people will want hormonal or non-hormonal methods or an IUD or an implant for different reasons. And if only one method is available to them, then that is unintentionally coercive. It's not towards that goal of full choice. They thought that they were solving the problem, and once we were able to talk through with them that not only did they need to offer more choices, but that also this was a short-term solution to a problem that was not going to be solved just by one influx of money, and that there were some other ideas for addressing it, then we were able to redesign the initiative. So these questions: first, does this bill impede access to the full range of contraceptive methods by privileging access to LARC or one type of LARC over others? Does it create or perpetuate obstacles for an individual who wants to stop or switch methods? And I want to say here that if it doesn't create opportunities for individuals to stop or switch methods, I think we should be very wary that there are likely to be obstacles to doing that. There are already a lot of barriers to removal for people, and if we're increasing access and a lot more people are choosing it, if there isn't a concerted effort to ensure that people can access removal, that it might be pretty hard for them to get a device removed when they want to. And that's really important because these are provider-controlled methods. Is the bill likely to result in patients being encouraged to make a specific choice about contraception, whether by the provider or by circumstance? So, for instance, does it privilege a certain counseling tool that providers must use or should use if they're participating in the program, thinking about, for instance, the website that Sarah was talking about earlier? Or is one method free and none of the others are free? And then to Sarah's point, is the bill trying to use LARC to solve a larger problem, or is it trying to increase access to LARC for those who want it? And we would hope that bills that we would feel really good about would be focused on the latter. Next slide, please. So, you know, again, this is policies that target specific populations are policies that you should look at a little bit harder, and you should definitely make every effort to talk to the population, stakeholders from that group that are being targeted. You can see in the bottom in purple, each of the groups that I'm going to be talking about do struggle with access to care as much as they are vulnerable, particularly vulnerable to coercion. So we do need to work to ensure that that groups that really struggle with access have access. We just also need to make sure that policies really prioritize and center their autonomy and decision making. So 3 groups that we wanted to lift up in particular. The first is people with substance use disorder. With the opioid crisis being really top of mind for people, being all over the news, we have heard about LARC being proposed as a solution to neonatal abstinence syndrome, as you know, as something that really should be encouraged for people that struggle with addiction. Certainly, people that have substance use disorder should have access to contraception and to LARC, but substance abuse does not justify a provider or a healthcare system making a decision for a patient or removing their autonomy, and we continue to need to focus on the person being able to make that choice, regardless of what they might be struggling with. People who are incarcerated. So being incarcerated is an inherently coercive environment. People are not free while they are there. Again, we do think that you should be able to access really good health care while you are incarcerated if you're going to be incarcerated. But we really need to make sure that in jails and prisons that there is comprehensive access to all the methods of contraception that providers or other people that are talking to incarcerated people about contraception are really trained in patient-centered counseling, and it needs to be clear that people can choose to stop a method and that people can choose not to use a method. And, you know, something that we've really been thinking about, too, is if someone does choose an IUD or an implant while they're incarcerated, will they know where, how to access removal if they decide they no longer want to use it upon release? Is there a way that we can really try to make sure that people have that information? I think that prisons and jails that are offering LARC have a responsibility to understand where removal is available in the surrounding area. If there's a problem with accessing removal for people that are not incarcerated or formerly incarcerated, then we can assume that it's really going to be challenging for people upon release, and I think that needs to be taken into account when designing these programs. And then young people. So LARC are sometimes talked about as a solution to teen pregnancy. I want to really always lift up Young Women United for really helping me to better understand some of the challenges with the frame of teen pregnancy prevention. One of them being that it can be very stigmatizing of young people who are parenting and of their families. Any program that is focusing on young people and their access to healthcare really needs to be sure that it does not stigmatize pregnant and parenting teens and their families. To also get back to that idea of LARC as a solution to some societal problem, you know, teen pregnancy is reflective of a young person's life and all of the different ways that they interact with the world and the systems that we all live in. And again, LARC is made available to them, but their decision-making really needs to be respected. And I think that we should always advocate for comprehensive sexuality education to be coupled with any effort to increase access to contraception for young people. And up here you can see that we have 3 other organizations that we think are really great resources. National Advocates for Pregnant Women, in particular, are really experts on the autonomy of people with substance use disorder. Justice Now has done some amazing work on access to contraception for people who are incarcerated, and in the resource we have a brief case study of some work that they did in California. And Young Women United, as I mentioned, are partners of ours in the LARC Access Project and really great experts on reproductive justice and access to contraception in general, but in particular on supporting the autonomy of young people. Next slide, please. Two other things that we just wanted to lift up, and Sarah talked about the targets for uptake a little bit earlier, so we don't want to dive too deeply into it, but did want to lift up the OPA recommended measures that, as one alternative to targets for uptake. They evaluate provision of most and moderately effective methods and access to LARC for all women in need of contraception, and then for postpartum women, and includes a box that says that this is not about setting benchmarks. It's not about reaching 100% of women that have access to these methods by any means. It's more a way to understand where there is limited or no access to LARC methods, so that we can figure out why that's happening and provide technical assistance to those providers. And then again, policies that do not consider the importance of LARC removal. IUDs and implants are provider controlled. It's not like the pill where you can just stop taking it or forget to take it. It's something that you need to go to the provider to stop using. And we really think that increased access to LARC insertions should include similar measures for LARC removal, including the cost of removal and provider training. I think about this a lot with immediate postpartum LARC patients who are eligible for Medicaid because they're pregnant and there's extended Medicaid eligibility will benefit from that, and they could choose an immediate postpartum LARC if they want. But then if they want to stop using it after a year or two and they're no longer on Medicaid because the eligibility has dropped, are they able to access removal? And again, I think that a healthcare hospital or any setting that inserts a LARC should really make a commitment that they'll remove that LARC for that patient if they come back and ask for it removed, even if they're no longer insured. But either way, we really need to be thinking about removal throughout all of this policy work. Next slide, please. So now to talk about forming your strategy and responding to these policies. We think that especially, people should really understand the concerns and priorities related to contraception of the communities that are most impacted by any policy that's put forward. Ideally, organizations that are going to have to weigh in on access to LARC should be led by or really in close relationship with whatever communities might end up being most impacted. But I think that if you're being asked to comment on it and you don't have a close relationship with formerly incarcerated or incarcerated people or people who have substance use disorder, then you really should make an effort before you can weigh in to connect with representatives from that group, organizations that work with that group to help raise up concerns that you might not be seeing or understand barriers that you might not know very well. We list out in the resource suggestions of voices that should be at a table when you're thinking about access to contraception, state-based advocates, local ACLU, local Planned Parenthood, local NIRH. The Black Women's Matter Alliance has a great list of kindred partners that are largely state-based organizations who can be great partners in this work. Providers from diverse healthcare settings, hospitals, Title X providers, fairly qualified health centers, private practice really understand their concerns and their challenges. Reproductive justice and civil rights organizations, and patient advocates or patients themselves. NIRH, as I mentioned, we've worked with over 170 organizations on the state and local level. So if you're looking for thoughts about who you might want to reach out to, we definitely encourage you to reach out to us, and we'll see if we can brainstorm with you. But how we really conclude the resource is saying that every bill is different, and every bill will require a tailored response. So that we really encourage you to reach out to us when you're facing something and not sure how to respond to it, and we can help craft a strategy together. Next slide, please. That being said, this slide and all the ideas on it are not in the resource, again, because we really do think that you need to have a tailored response to each of these bills. But that felt like kind of a cop-out for this webinar. I felt like I should probably include a few recommendations or examples or ideas. So I thought about it, and these are some of the things that I wanted to share. We talked about this a lot, so I just want to reiterate, get clear and be clear about the intentions of the policymakers and the goals of the bill. really, maybe the intentions of the policymakers aren't great, but you actually are able to figure out a way to work with them and to craft a really good policy. But you should know that going in, and you should know that the whole way through. Same thing with the goals of the bill. We throw out a goal for the bill that we thought might make sense, addressing barriers to LARC access so that all people, or the people impacted by the policy, can choose the method of contraception that's right for them. That's what we think these bills should do. There might be other things, though, and you should just make sure that you understand that, and that will help inform your strategy, how you talk about it, and how you really advocate for the bill to be implemented, changed, whatever step of the process you're in. An idea that came up recently, we were talking to a set of state advocates who are working with our Medicaid office to increase reimbursement. This would be to address a lot of the barriers that we've been talking about, and also to really help with stocking. And they think that it might happen, which would be really great. It would be really meaningful for access. But of course, when reimbursement is increased, then you start to worry about what incentives are being put out there. So one idea that we've been discussing and we'll continue to explore is, can that initiative be explicitly tied to the state simultaneously putting out resources for training on patient or person-centered counseling, or for a summit on patient autonomy where providers from across the state would be brought together to talk about the experiences of their patients and what they need to really have the time and the tools to focus on their patients and ensure they're choosing the method that's right for them. And we think that by, the state could do both of those things next year, and they could do them separately, and hopefully it would still have a good impact if they do that second piece. But the idea of introducing these two things together in some type of way is exciting to us to think about, the state really demonstrating its intentions there. This next point, don't sell out your values. We've thought about this a lot when we've been thinking about advocacy with private insurance payers, asking them to follow in the footsteps of a lot of Medicaid offices to debundle insurance reimbursement for immediate postpartum LARC. And I just want to say that, a lot of states, as I mentioned, have debundled immediate postpartum LARC in their Medicaid program. The idea was that private payers would follow. And from our experience, we haven't really been seeing that, and our partners have been talking to private payers, and there's been some resistance. That's another question if people want to chat in. If you have had success with private payers debundling immediate postpartum reimbursement, or have ideas for how to do that effectively, we'd love to know. But, the idea was that private payers would follow. They haven't been, and that's really an issue of equity for us too, both in that people with private insurance don't have access to this service, and now the only people that do are low-income people. So are those the only people that are getting counseled about LARCs immediately postpartum? That's a real concern about equity. But when we're talking with our partners about how to go into these meetings with private payers, we know that cost effectiveness is going to be the most important data point. We're not blind to that. But our guidance is, yes, lead with that, talk with that, have the data around that, but ensure that you also say the reasons why you think it's important about access, it's about equity, it's about women's health. Make sure that those things are said even if you don't think that they're hearing them. At least bring that into the room. Advocating for metrics that align with your values. So, I think that there's a lot of consensus around the idea that targets for uptake, targets around numbers of LARC placed are really concerning. But, if it's possible to think about it, think about what metrics you would really want. This idea came from Aisha Chowdhury, who is at EverThrive, Illinois, and coordinating a contraceptive justice coalition there. And the coalition is a really broad, diverse group of stakeholders. They are crafting an initiative around access to contraception, including LARC, all together. And one of the things they do need to do is set out metrics. There's a lot of funding put into this initiative, but they're really working together to think about what are the type of metrics that if we meet them, we know that the goals that we as a group care about. And again, it's providers and reproductive justice advocates and everybody in between. What's something that we can agree upon that if we met this, we would all feel good about it. So I think dreaming big and putting out those proposals is a exciting idea. It might not be accepted, but seems like a good practice. And I think we're always looking for new metrics as a group of people that advocate for LARC anyway. So if you're not able to use them, let us know, and maybe we can. And then consider potential unintended consequences and offer policymakers alternative language or a structure to avoid them. I think hopefully that's pretty clear, but I think that you have the time to sit and think about a policy and what the challenges might be. And for us, we always want to make sure that we're not just saying, this doesn't look good, but thinking about what do we want to propose instead, coming to the table with a solution. So those are my ideas to consider. Next slide, please. Then finally, just quickly, the support that NIRH can offer. Funding, as I mentioned, we provide funding to state-level organizations. Our request for proposals usually comes out in the fall, and we, would encourage people on the state and local level to apply. We don't fund national organizations, but I can definitely talk to people offline about our funding opportunities. We also provide policy analysis and development, research and materials creation, communication strategizing, and that could be coming up with a media plan, coming up with talking points, coming up with an internal strategy, really broad array of things. Advice around coalition building, I think that's particularly important when it comes to working on LARC policy, and then connections with national and state level experts, probably like many of you who are on the webinar today. Next slide, please.
So we are a much smaller organization, and we have a very small policy shop, but we can offer some support. We offer trainings with Sister Song whenever possible that can help introduce stakeholders to the issues I raised in the earlier part of my presentation. We also analyze specific proposals, and that's not just limited to legislative proposals. So recently a provider came to us. They had gotten an offer from an outside funding source to reward clinicians who were prescribing a certain number of not just LARC methods, but most and moderately effective methods, so including non-LARC methods. And we were able to talk through what the impact of that proposal would have on the incentives that their clinicians had and what kind of care they provided. So we know that when people feel like they've weighed all of their options, when patients feel like they've weighed all of their options and they've chosen the methods that works best for them, they stick with that method. When they feel like they've been sort of pressured into a method, they might agree in the moment and then leave, having built up distrust of the provider and not actually having gotten the care that we wanted. So sometimes it can help just to talk through those ideas, to talk through the bill, identify the red flags, or develop improvements. You can always email me. My contact information along with Jenny's is on the next slide, or folks can always reach out to our house account. And that's on to questions.
Next slide, please.
Great. This is Lauren. I'm going to unmute everyone. If anyone wants to ask their question over the phone, you are also free to type it into the Q&A box, and I will verbalize it to the presenters.
The conference has been unmuted.
Does anybody have any questions?
While we're not having questions, I'll just perhaps close by saying that we really welcome feedback from all of you on this resource and on this webinar. This is a nuanced issue, and I was actually in Knoxville, Tennessee last night for a conversation facilitated by our partner Sister Reach about access to LARC and coercion, and it just came up over and over again. People were sharing stories of not being able to get a device removed that they wanted removed, and people were sharing stories of feeling really or feeling like they couldn't access the device and being talked out of it when they really wanted it. It's hard to think about exactly what the right answer is here, and we hope that this will be a good offering to that conversation, but we really do want it to be a conversation. We're grateful for, again, what we've learned from all of you, and hope that you've learned something from us. I also wanted to acknowledge Sister Reach and Sister Song and NIRH Pro-Choice Missouri, who are partners of ours that all graciously reviewed this and offered their feedback. So a shout out to them.
And it looks like we have gotten a couple of questions in the participant line. One of them, the first one I see, is some feedback about the bill in Virginia. Jenny.
Sorry, is it asking you for feedback on the bill in Virginia?
They included a link, but this might be something we can follow up on, just because we have to take a peek at it. But they included a link.
Oh, okay. Cool.
Some other questions are, has there been any work done to increase access and assess the need for trans people seeking LARC? I don't know if you guys have any thoughts on that.
Sarah, I don't know if you have information about that. That was actually something that came up in the conversation last night as well. And so I am not an expert on it, but would be happy to see if we can find some information on it. I guess from the conversation that I was hearing last night, it seems like there isn't a lot of research on this, and that people that are using hormones might have uteruses that are too small to insert some devices, particularly IUDs, of course, and that you also have to think about the interaction of hormones. It's something I can't really speak on expertly, but I learned a lot about it last night, and one of the things I learned was that there weren't good answers. But we're going to try to follow up on that, and we'll track who asked that question and try to share more information.
Another question is, can you say a little bit more about the training that you provide for clinicians and administrators? Sarah, I think this is your question.
Yes. So often Monica and I, or Monica is the executive director of Sister Song, and Cindy Pearson, the executive director of the National Men's Health Network, will meet. So a recent example, I think last year, I was out on maternity leave, and they met and provided a training for Planned Parenthood affiliate providers. And walking through much more in detail, I try to keep myself in time limited, but walking through in much more detail about that sort of full scope of what makes for good contraceptive counseling, what makes for good clinic practices, recognizing that there are a ton of burdens placed on people who want same-day insertions, but also that those same burdens exist for folks who want same-day removals, right? So that if a clinic is prioritizing, as they should, same-day insertions, they also need to be orienting their staff towards same-day removals and expressing ultimately this value of respecting patients, right? So that if a patient comes forward and says, I'm not happy with my LARC, I want to get it removed, that there is that culture reinforced from the administrator level on down of taking those concerns seriously, and not just sort of, as we know happens too often, oh, you'll get over it, oh, you're fine, you're overreacting. Taking those concerns seriously so that a patient walks out of that encounter having been respected, having their questions answered, having the removal if they want, and that not only leads to a better encounter for that person, but has all kinds of spillover benefits, right? When someone walks out feeling like they weren't taken seriously, they're much less, their distrust in the overall healthcare system grows, right? They're much less likely to engage in the way that we want them to on completely unrelated healthcare problems because they've been told they're not going to be taken seriously.
Great. Any questions in the last couple of minutes?
So we'll send out a recording of this as well as slides for folks.
Yep. And we'll get back to the few people who have some questions offline. And if you have any questions, like, email us here.
Thank you.
Thanks, everyone.
Thank you all.